Well, good morning, everybody. Today's Wednesday, August 21st. My name is Jens Chapman, and welcome to the beautiful Seattle Science Foundation facilities. And these are our STED Talks, Spine Technology Education. And the D is discussion, discovery, debate, discourse. And we have a really cool special program today about something that's become an increasing problem. Dating back to my era as a young surgeon in 1990, thinking about a spinal infection was one of the things that was on our differential, but it was a remote possibility, and this seems to have become an everyday problem now. And we don't have answers for it, but if ever there was a real challenge to an interdisciplinary approach, it is this topic of de novo or new spine infections, so spinal column infections of the epidural space, of the disc space, of the vertebral body column. And here we have a duo today, and that is Dr. Reznicek, I hope I pronounced the name correctly, an infectious disease doctor, and Dr. Placide, a spine surgeon, orthopedic spine surgeon, and they both come from the East Coast, from Virginia Commons University, which is particularly cool. Good morning to both of you. I hear that both of you are live. Is that right? Can we have a verbal?
That's correct.
Correct, yep.
Thank you both. I'm going to introduce you in greater detail later for the lecture part. We always have a couple of cases that our fellows have kind of brought out, and we would love to hear your commentaries on it. None of them are curveballs or gotcha things. They're all things that come out of a more recent practice. I think we have 4 cases lined up, and we'll go through them relatively rapidly so we can get to your talks, but we'd love to hear both of your opinions. So Dr. Hogshead's going to come up first. He's one of our new fellows. August 1st is always the start of new times, and Dr. Hogshead from Fort Worth, Texas, Dallas, Texas, and he had barely arrived when he got his first infection case, right? So welcome to Seattle.
Thank you, Dr. Chapman. Let me pull up our PowerPoint here. Can we see the PowerPoint here or there?
Yeah, right there.
All right, very good. Good morning, everybody. I'm Cameron Hogshead, one of the new orthopedic spine surgery fellows. This was actually one of my first call cases coming on this new fellowship experience. No disclosures for this talk. So this is a 57-year-old female who presented with worsening neck pain about onset 5 days prior to presentation with progressive upper extremity weakness. Quotes, she was unable to move her arms since 2 days ago, a traumatic onset. She has quite a history, a comorbidity of diabetes, once uncontrolled, now improved, previously in the 11s, noted to be a year ago, high blood pressure, peripheral arterial disease, chronic kidney disease. She has bilateral above-the-knee amputations from chronic osteomyelitis wounds and peripheral vascular disease. Morbid obesity as well. She has a history of a stage 4 chronically infected sacral decubitus ulcer, and she had recently, about a month ago, was placed on PICC-line IV antibiotics, vancomycin and ceftriaxone for this. She primarily mobilizes with a wheelchair at baseline, has a chronic indwelling Foley. Before this, she had full strength in her upper extremities, 5 out of 5, and now you can see her exam here, Asia score, really just shoulder shrugs, completely unable to move any of her upper extremities or even lower extremities on initial exam. She was in a little bit of delirium, noted as well, so there might have been a compliance issue with her exam, but overall she was really only just shrugging her shoulders. She had blood cultures that she came in that were positive for Pseudomonas aeruginosa and Staph hemolyticus. Her vital signs were stable upon arrival. Those were her infectious labs, mildly elevated white blood cell count. Her CRP was elevated, ESR was elevated, as you can see there as well. She did report some sensory issues too from the trunk down. So MGOA, obviously very severe in her case, and then the site score, which was recently developed at this institution as a standardized evidence-based system for treating spinal cord and spinal system infections. The spinal infection treatment evaluation score, obviously in this case indicating surgery for her given the progressive paralysis, as you can see there. Here's a video of her cervical MRI. So you can see there that she has chronic instability of C2 on C3 with spondylodiscitis, osteomyelitis of the vertebral artery, in addition to a probable compressive lesion posteriorly at the C2-3 junction, causing severe spinal cord stenosis.
I'll start with Dr. Reznicek, maybe. Dr. Reznicek, so we're here on the far western side of the US, in the middle of nowhere, up right below the Arctic Circle. No, just kidding. But we have been inundated with these kind of cases. How is it in the East Coast? Are you seeing far more of these kind of horrible medical disaster patients coming to your facility in Richmond?
Yes, it's exactly the same. I was going to say this could be one of our patients. And the literature shows that we're definitely seeing an increase in incidence of these infections. I think, people are sicker, they're living longer. We're seeing more patients on hemodialysis that are coming in with infections. And we here in Richmond, unfortunately, have a high rate of intravenous drug use, so that contributes too. But yes, I mean, we have these cases. Dr. Placide and I share these cases probably at least once a week. So it's same here for us.
And Dr. Hogsett did a very nice job. Thanks, Karen, for that overview. So should we get something that we haven't talked about yet or shown you? So you saw, if you go back to your workup slide, this obviously doesn't do the entire diagnostic spectrum justice. I would add, we routinely in these patients get a neural axis MRI. What should we get in terms of vital parameters, SED rate, CRP? Is the SED rate still relevant? Should we get something else that you would really like in your facility?
So I'll talk about this later on, but for me as an infectious disease doctor, I think SED rate and CRP, I use them more for trending. So for example, if her SED rate and CRP were completely normal, she obviously still has a surgical issue. So we use them here more for trending. There's also literature out there that shows that it's not very helpful while they're on treatment for spondylodiscitis. So it's good to have them as a baseline, but also, I mean, she has so many comorbidities which drive your ESR and CRP, so it's hard really to know what's causing those elevations. That's exactly, I mean, you guys got blood cultures, which is exactly what we always ask for, hopefully prior to antibiotics. And then I guess I would just want to know a little bit more about this chronic sacral wound, why she's on therapy. We typically don't keep people on antibiotics for that long anymore for these sacral pressure injuries, but that's probably an easy source for bacteremia in her.
Yeah, it was debrided surgically at an outside hospital, and cultures were found to be growing Pseudomonas, as well as Enterobacter cloacia. And so I believe the reasoning for why she was placed on PICC-line IV antibiotics, and I do think that she came in septic at that time and was bacteremic, and so that was.
That's why they did. That's why they did debridement and IV antibiotics. So that could be your source, but she also has a PICC line in place, so also a possible source. And she's not on dialysis, correct? She doesn't have a hemodialysis access.
Correct. No dialysis yet, but she's getting close to it. CKD4.
One other thing that I always love to see, and I don't want to preempt your lecture part, I like albumin levels as a basic screening tool for nutritional status. And a patient like this is obviously very difficult. Is there any value towards having some handle on the immune status of the patient, at least the nutritional status?
Yeah, so this is actually a hot topic in the prosthetic joint infection world of should we be doing pre-albumins or albumins? And I agree. I mean, I think we see these patients with high BMIs, which definitely does not mean that they are nutritionally at an adequate stage. So yes, I agree. We are starting to get albumin levels on our patients. We're just seeing how much nutrition plays a role.
Did you have a plain CT also, sagittal CT?
We did not. We weren't able to obtain a CT, and so we did an O-arm spin intra-op prior to our operation.
So it's not my case. Dr. Placide, what would you like to see? So we usually get a neural axis MRI. Do we need contrast for that, or do you see enough? What's going on here in short? What do you see happening? What would you like to have to make sure this patient be
So
treated?
certainly would have a CT scan pre-op would be ideal. And I agree with the neural axis imaging. If somebody has a progressive neurology, I'm okay with fixing that problem first in the OR and then scanning the rest of the spine, provided I don't have any physical exam evidence that there may be a thoracic or a lumbar infection. If we had time. How long has she been essentially quadriparetic? Do we know?
For 2 days. She said that she was normal just 2 days prior to that, and then over the course of 2 days developed
And that's just part of the discussion with the patient and the family about recovery. I still think it's reasonable to operate. I probably would do this urgently. The idea of the CAT scan is to look at significant bony destruction to see if there needs to be any ventral reconstruction. But I think in this case, I would do posterior decompression and occipital cervical stabilization.
So you'd go to the...
And of course, if she is wheelchair bound, this is critical for her because she won't be able to propel her wheelchair. She can't get her arm function back.
All right, Cameron, take us forward and open this up for discussion.
Yeah, so that was our thinking as well. We took her urgently to the OR and underwent a C2 to T2 posterior fusion and decompression. C2 pedicle screws, you can see from our CT scan there. There was epidural phlegmon as well posteriorly that was decompressed and sent for cultures. And this is kind of where we ended up with our alignment. She's 2.5 weeks out now, and as just recently saw her, shown pretty significant improvements in her strength. She's about at least 3 out of 5 throughout now.
So I'll ask the surgeon first, and then I'll ask Dr. Reznicek, our infectious disease specialist, second. So what do you think about this kind of a posterior multi-level approach? Obviously, posterior surgeries in the C-spine are much more morbid. This is a morbidly obese patient, large integument, dead space potential. So what do you think about what was done here? Is that something you would have done?
I think that's reasonable, provided there's adequate decompression. That's critical here. And the reason I mentioned occipital cervical, the question is, would we have to undercut up to C1 and have to look through the MRI scan again and CT? But I think that's very reasonable. I don't know that I would extend it to T2. Again, that's where the CT would help with planning the surgery. So stabilization and decompression, regardless of the technique. And it sounds like she's doing well.
I admire, Cameron, the proximity of the C2 screw to the vertebral artery. Were you aware of the vertebral artery cavitation at C2 as you went in on that case?
We were, yes. Yes, sir. We did a intraoperative CT scan just because we weren't able to obtain one more urgently. And so we took kind of a bony note-taking with our O-arm spin prior to putting in our screws.
Now, Dr. Rose,
that screen is relatively small, so I really can't comment on the instrumentation and the technique. The screen it's not the whole screen right now. So,
oh, okay.
But very good point. Very good point.
Yeah, I would always like to have a CT beforehand, just for that reason. That I think Dr. Placide's point is very good. We need to have the phlegmon gone, and I like to preserve C2 wherever possible. I like to leave the C2 spinous process intact. I would always want to avoid going to the occiput, especially given that this patient is wheelchair bound, if at all possible. And maybe go to C1 with segmental fixation if C2 does not provide an adequate fixation. Now, Dr. Reznicek, this is going to be a recurrent theme. Here's a patient with chronic infectious state, I'll say chronic suppressive antibiotics at this point in time, with a sacral, I don't even know what class 3, class 4 lesion. Does it involve bone?
Stage 4.
Stage 4.
Yep.
Here, our colleagues put hardware into an actively infected patient. What happens when you, as an infectious disease doctor, see hardware put into an actively infected patient?
I cringe, but no, that's okay. So Dr. Placide and I work on these a lot together, and I think this is where the multidisciplinary approach is absolutely essential. So I work with ortho, spine, and neurosurgery here on these patients. So first, I always request at least 3 to 4 intraoperative cultures. We had some issues here at our institute where someone was getting 16 to 20 cultures, and then some were getting 1. So we've tried to standardize that because just because that staph hemolyticus and pseudomonas was in the blood, I'd love to know what's actually in your intraoperative cultures, because this patient has a PICC line, so more likely to have a polymicrobial bacteremia. But what exactly is in that where you're in your intraoperative cultures? And I can't see it too well. But then, I mean, similar to what you have there, we do 6 weeks of IV antibiotics, and we can talk later about where that recommendation comes from. And then I try to suppress them with something. Of course, Pseudomonas is tough. You only have one oral option, which is Cipro or levofloxacin. And I think the key, and I don't know how it is at your institute, is Dr. Placide and I see these patients together in follow-up. And so we have clinic together on Tuesdays, and to me, it's the most important part because I can look at the x-rays with him, we can look at the fusion, we can see how the patient's doing, and that helps me determine when to stop the oral suppression, because it's just not feasible for someone to be on a fluoroquinolone for lifelong.
I love hearing that you have a clinic together. That's amazing. We have
he loves every second of it, doesn't he? Yeah,
Hey,
so
hey.
I can't promote that enough. I just went to the Musculoskeletal Infection Society meeting, and there's very few centers who do this. I started it when I got here 9 years ago, I guess, but I am in clinic with Dr. Placide as well as some of our joint and trauma surgeons, and it's essential. I don't know how you can, I don't know how to do it without being in clinic and seeing them together. And the patient loves it, to be able to see us together and hear the plan that we come up together.
I congratulate your medical system for that. I'll repeat that later, but we have fantastic ID doctors. I'm really proud and happy to work with them, and we interact and communicate a lot, but I can't fathom that our organization could put us together in one clinic. It would be a dream come true. One more question for Dr. Hogshead before we go into the next case. Is there an effort underway to kind of clean up the sacrum, debride that, do something about that?
Yes, our plastic surgery team has been managing the sacral decubitus wound and with local wound care and plans for, once clean, muscle flap and coverage.
So that is underway. I would find
correct.
that an essential component together with nutritional optimization.
Absolutely.
So there's a social disease component probably to this also, that this was neglected and dragged out so long.
Right, so a nutrition consult as well, and kind of the
Is there a sacral debridement going to take place, or sacrectomy or anything like that, or just
It already did. So I think initially before she came, and now it's kind of in its healing recovery
Highlighted,
process. Correct.
Chronic ulcers, not a good idea.
Yeah, I just want to comment on that. We have a lot of patients with sacral pressure injuries, and the issue is I don't know if she would ever be an adequate flap candidate, given her nutritional status, and you have to absolutely offload that area the entire, for 4 to 6 weeks afterwards. So we struggle with these as well. Just doing one component debridement versus, sacral debridement, et cetera, isn't really going to cure this problem. So, flaps fail a lot of the time, and especially sacral flaps. And if you have someone that cannot offload that area, it's going to be a tricky situation.
Very insightful. Again, the benefit of multidisciplinary work. Dr. Julius Gerstmeier is one of our 2 research fellows. He's from Bochum, Germany, and they actually have a very active interdisciplinary group working there between trauma surgery and infectious diseases. Dr. Gerstmeier has a case. I don't know what it is right now, so he'll surprise us with that. Dr. Gerstmeier.
Good morning, everybody. So I'm presenting an elderly person, 82-year-old male, that presented initially to an outside ortho department with worsening lower back pain and right leg radiculopathy. He didn't have any systematic signs of infections, but reported that he had experienced increasing sweatiness over some time. His lab work showed a little elevated infectious parameters, but as we already discussed, this could be due to numerous reasons. The lab blood work did come back with a lactococcus, so he was treated with an appropriate antibiotic. As we just talked about, albumin, his is slightly decreased out of the norm, but not horrible. His physical exam didn't show much, so there was no ulcers, no rashes, no coughs or any other signs of abdominal infections. He does have some medical comorbidities, mainly cardiac or cardiovascular, so this is why we received a bypass a couple of years ago. So I just wanted to share this first MRI with you. So I have a small epidural abscess, L2-3, with some erosion of the vertebral body.
So nothing special, right? Another day at work.
Another day at work, nothing where you would say this requires urgent surgical care. So
Patient is still ambulatory, right?
yes, he's still ambulatory. He receives his targeted antibiotic therapy over a Medline. So he comes now to our clinic. He's been on antibiotic for 4 weeks. He has persistent pain, so his physical exams does not show any changes. He still doesn't have any signs of a systematic disease, a systematic infection, or no change in physical exam. On the right side, you see also a normal neurological exam, and now we have this image. So we'll have a little worsening of the abscess with now bony erosion that has progressed at the L1 level, and some stenosis.
So I'll go with Dr. Placide first. So epidural abscesses. I don't want to preempt anything in your talk, but can you just briefly give us your outline of what's up with epidural abscesses? Are they kind of the same disease continuum as spondylodiscitis? Are there subvariants that are relevant here? What happens with epidural abscesses that we should be aware of, and what's the interplay to the spinal column itself?
Right. So certainly we see epidural abscesses without any spinal column involvement. The ones that worry me the most are the mid-thoracic, where the cord is ischemic, because the infection itself creates this local vasculitis, and they may have relatively mild compression compared to, say, an epidural tumor or something like that, and can progress to a severe neurologic deficit. But smaller epidural abscesses, even at cervical, thoracic, lumbar, I'm willing to observe those without a neurologic deficit. Then, of course, you have the other scenario where you have a spinal osteodiscitis that is associated with an epidural abscess. And I still would manage that the same, and that'll come up in the talk about the management with respect to the spinal column infection. So
microbiologically, Dr. Reznicek, was the patient undertreated? Is this an ischemic area? This is originally maybe a hematogenous disease. I'll just postulate that. What went wrong here? Should we have immobilized the patient with a brace?
So I think I may have missed it, but did we have positive blood cultures or any positive culture data?
On the first visit to the outside clinic, they did take some blood cultures, and it showed a leptococcus, and it was treated.
Lactococcus.
Yeah, so that's a relatively uncommon organism and can be a contaminant. So I'm a little concerned that we're not targeting the organism here. So was there ever any other culture data obtained or no?
No, not prior to our treatment.
Yeah, so in this age group, 82 years old, these are usually a hematogenous process. So I would actually Often I ask a lot of questions, any recent prostate biopsies, nephrolithiasis, recurrent UTIs, et cetera, because I'm just not believing that the lactococcus is your pathogen. So I guess I would try to get more information to see what exactly, because I'm not sure ceftriaxone is enough in this situation.
So maybe under treatment. All right, so what do we do now? Dr. Placide, the patient's coming back, right? If you go forward again, Julius. There is radiographic, at least MRI imaging progression. Was there CT obtained? Is there osteolysis taking place now?
Prior to surgery, there was a CT obtained that I,
sure.
of being compressive, didn't include in the talk, but it has shown some L1 progressive erosion.
So let's say this patient was very unhappy with his treatment here in Seattle and took a cross-country flight to Richmond. He's going clinic now, and you two are sitting together, and I'm sure the patient is thrilled to see two bright, engaged doctors from different specialties talking about them. What would your consensus be? Is this patient a surgical patient now? Was this patient undertreated? Do we need a biopsy of this area? Where do we go from here? What does our Seattle patient get as advice from you in Richmond?
So that's exactly what I was thinking, your latter statement, and keeping with Dr. Reznicek's comment, even though the utility can be as low as 30%, a guided biopsy may be a reasonable option after the patient is off antibiotics to see if we have the correct organism. I understand he has stenosis, he has pain. I would like to confirm that we've adequately treated it non-operatively before operating, because if you're addressing the pain, just going and doing a disc debridement isn't going to solve that. If he's having progressive destructive changes, it's going to need to be stabilized. Julie, any thoughts?
Yeah, so I agree with Dr. Placide. I think the initial thing is, do we have the correct organism? And is there any way to biopsy this area? There is a new test called the Carius test, which is a blood test. It's a cell-free DNA test. We use it occasionally here. There are small studies of it being used in spine infections, and sometimes it may come up with an organism for us. So that would be something I might try in this case. So we use it in situations where a biopsy is not feasible or not safe, especially in the C-spine. So I think really I'm concerned that you don't have the right organism here.
And then the question, if this is hematogenic, where is there still another source that is the patient's not revealing, or it's not
Right.
symptomatic, and certainly get the rest of the spinal axis scale imaged.
Yeah, I can't tell you how many times people don't tell us that they have a prosthetic joint infection in their knee, and they, were treated for MSSA 5 years ago and forgot to mention that. So it's always helpful to know that.
All right, so let's take it forward, Julius. What do we do?
So I just wanted to include in the interest of being comprehensive, include the side score, which shows a moderate infection with some instability that we discussed, and surgical management optional. So this just to give a brief summary what we already discussed. And we went on and did a posterior fixation L2 to S1 with laminectomy and decompression.
So the patient went to surgery then?
Yes.
With a single level decompression fusion?
No, L2 to S1.
L2 to S1, wow.
Yeah, large construct.
And why the multi-level construct?
I
don't know, okay.
Due to this image, I think
stenosis
because of the multi-level stenosis, I think we opted for long decompression and stabilization construct.
Got it, okay. How did the patient do?
It's doing fine. It's now on lab revealed the same organism, so we didn't have a change in pathogen or causative pathogen, and he is doing fine. He's on appropriate antibiotics and doesn't have a recurrent infection.
Was this a phlegmone or was this a liquid abscess? What did you derive from the operative note?
I can't recall that. I'm sorry.
Okay. If you go back to the score, so we use something called side score. We have a interest in that because we published on that. But do you use any scoring systems of sorts, Dr. Reznicek, Dr. Placide, as you look at these patients to kind of quantify what's going on and try to predict whether this will require surgery in addition to antibiotic therapy?
Yeah, absolutely. So a couple of things that I do, I certainly review the site score. I go over it with the residents and we use that. And then we include other factors that are predictive of failing non-operative management of spinal column infection. And we'll talk about it a little bit in the talk. And I actually review this with Dr. Reznicek as well. So if we looked at this patient, for example, I probably would have limited it to L2-3 with the interbody debridement, maybe an interbody device, titanium, and just a one-level fusion. It didn't seem like he was symptomatic from the other stenotic levels. Certainly not faulting what was done. I think I might have been a little less aggressive.
Yeah, actually, I don't know this case. The next two cases I'll know of and I'll take ownership of. I would have probably actually done what you did. I would have decompressed and fused L2-3 with a titanium cage, not a PEEK device. And I would have, if this highly relevant, but I'm not sure about that, decompressed the other levels without hardware, but I'm not sure I would have done it at the same time, depending on how sick the patient is. I would have focused on the infection in that bad segment first and fought the other battles another time, but probably not with hardware. So I'm surprised to hear that there was a multi-level fusion done. We'll see how the patient does. But the concept here was, or the main teaching point of this case was progression of a disease, unusual pathogen, and what to do as medical therapy does not succeed.
Exactly.
Thank you. Next, we have Dr. Mark Kramer. He is a neurosurgical fellow with us, and he is a graduate of the neurosurgery program at the University of Wisconsin. It's great to have him here. He came in for a little bit of a culture shock after the wholesome Madison, Wisconsin environment. He is now in Seattle, and welcome to Seattle.
Thank you. My name is Mark, one of the spine fellows here. I'll present a case on a 6-year-old woman, approximately 6-year-old woman who presented with some neck pain and right arm weakness. She does have a history of diabetes. She has a history of hypertension and some dentition issues. She had no previous relevant past surgical history. In regard to her symptoms, about 5 days prior to presentation to us, she initially presented with some neck pain. She was actually seen by her outpatient primary care team and was prescribed some muscle relaxers. And then a day after that, developed some fevers, became quite febrile up to 104. And then just one day, and these actually resolved a day or two later. And then one day before presenting to us, she developed some acute right arm pain and some paresthesias in that right arm. So in regard to her physical exam, approximately 5'5", 80 kilograms. She did not report any bowel or bladder issues. She had some weakness in that right arm, as you can see here, and also some sensory deficits. She did not have any pathologic reflexes. I report some of her pertinent labs here as well. She had some leukocytosis, the 12 ESR, CRP also elevated, and she also had some blood cultures drawn given her fevers with initial speciation being a staph species, which these ended up growing out to MSSA. Here's her MRI that she presented with. So this is a T2 sagittal on the left, and then in the middle and on the right, we have a kind of a T2 fat suppressed sequence, and then the axial T2 on the right. You can see that she's got pretty extensive prevertebral soft tissue edema. She's got some enhancement also of those soft tissues. She's got a little meningeal thickening that they also noted on the report. And you can see that the C5, C6, and C7 region demonstrates a pretty severe stenosis. The report specifically also says that there's no absolute evidence of infection, but given her MSSA blood cultures. There was obviously, and some of the other features noted on the report, there is definitely concern for infection.
So if we have a patient in distress, do you have a CT scan? I know this is my patient. We have a CT. Thank you, Mark. Awesome.
So here's the CT.
Dr. Placide, do we need MRIs contrasted? Do we need to subject these patients who are frequently afflicted with kidney disease and other ailments, advanced diabetes? Do we need to get contrast agents into them to kind of have a really perfect diagnostic visualization as a plain MRI with some fat suppression may be enough?
Yeah, I typically don't get contrasted studies. Usually from the other imaging, you can tell that it's infected or where it's infected. We didn't have the entire series of the MRI, but certainly that's concerning. I would probably get upright plane flexion extension x-rays too. But to answer your question, no. And I battled the radiologist with this, and I'm like, it's not really going to change my decision making if you put contrast. That's just my thought.
I agree. Dr. Kramer, Wisconsin, major academic center. Did you routinely have to get contrasted studies? Did the patients get gadolinium or?
If there's concern for infection and the radiologist, we have the time to think about it. Sometimes we would ask them to, but otherwise, no.
Not a routine. Dr. Placide, what do you make of this? And don't worry, Dr. Reznicek, I'm going to come to you because this case has a twist, but it's not a trick question. What do you make of this constellation or this frequent conundrum of having an advanced degenerative disc disease plus infection? I mean, this patient, by the way, could not have gotten flexion extension films. I saw her in the ER. She was an extremist. She had a flaccid, mostly flaccid right arm, and she had severe pain. She basically held her arm above her head, trying to be comfortable. So getting a flexion extension film in her would have been a nice add-on, but honestly not feasible.
Understood. Yep. So the other question is this all degenerative, and is there an infection somewhere else that's causing her systemic signs and symptoms? But clearly with this neurologic deficit, I still think she needs an operation on her cervical spine. And if you're going to be aggressive and get a good decompression, it would be a couple level corpectomy, 2, 3, 4, 5, and 6. And certainly send that off for all the cultures that we typically do. And then, you question, do you need a posterior stabilization with a 2-level corpectomy? That's kind of a in between, right? You do a 1 level, you can sometimes get away with it. I'd have to look closer at the facets. If there's any sort of destruction posteriorly, I would probably posteriorly stabilize it as well. But I think a 2-level ventral corpectomy, at least because of her neurologic status.
And I'll ask Dr. Kramer to move forward, and I'll ask Dr. Reznicek. So I'm in the OR now, so let's move forward. What do you want me to send off? What do I do there? So I did not do a 2-level corpectomy, and we'll see where this goes in a second. But as Dr. Kramer pulls these images through, Dr. Reznicek, what do you want me to send off? We found liquid pus. We went to C4-5 also because she had a clear C5 palsy. What should I send off?
So, I would think that this would be the MSSA in the blood, but you also threw out a lactococcus or whatever in the last one, so which is not a common cause. So I usually request 3 tissue or fluid samples and 1 bone sample if possible. Dr. Placide and I usually review these cases ahead of time. This seems like infection, but obviously if we're worried about tumor, we request bone to be sent for pathology as well. But I would say 3 tissue or fluid samples and 1 bone sample if possible.
So fluid, like standard syringe, package the syringe, send it off, or do we squirt it onto a swab? Give me some more detail, because we frequently get criticized and not all of our ID doctors seemingly think alike.
Yeah, and I think your micro lab probably directs some of that too. So I prefer actual pus fluid. If you can syringe it off and put it in a sterile cup, I guess a lot of it depends on what you see intraoperatively, but I try to avoid swabs if possible. The micro lab would prefer a piece of tissue or fluid if possible, but a lot depends on what you see intraoperatively.
Now, Dr. Placide, back to you. So I did not listen to you. I'm going to just presciently say I should have. I was very happy with the 3-level decompression. I used allograft, as you can see, used rigid fixed angled screws, bicortical purchase. Her bone was surprisingly good. We were prepared for corpectomy. We usually are, but I washed this out with, I think, 12 liters through a cysto tubing with a small EVD catheter at the end so I can get behind the vertebra. I create a conduit. And surgically, this was like a, honestly, no bragging, 2-hour surgery. Critique me.
Where was the liquid? Where is the purulence?
It was at 5.6. So on the MRI, in retrospect, you can actually see it. 4.5 was just a very advanced collapse. And again, that's where her main neurology was, but she did have a actual liquid aspiratable disease. And Mark has been so kind to look at this case. He did not know it until yesterday. Despite a very busy order, he put this together. So there was clear pus behind 5.6.
Okay. Okay. So the reason I'd mentioned corpectomies is the posterior or the compression on the ventral cord, some of that is behind the bodies. And with the severe neurologic deficit, I just thought being very aggressive would be the answer to help with improving the neurology. I agree that the MRI is a little bit difficult to see. And seeing the frank purulence come out from behind, you said C6? C5, right. So just removing the entire vertebra, obviously you're going to have a better debridement of the infection. I mean, the construct looks fine. I mean, I think that's in the, that's certainly an option, is doing a 3-level ACDF versus a 2-level corpectomy. I just would have been more aggressive.
We have a question from one of our panelists, Dr. Amir Abdul-Jabbar, one of the partners at our group, wants to know what type of graft would you have chosen if you did do a corpectomy for this patient?
So I probably would have used an expandable titanium cage. I probably would not have put a fibular strut, for example. Probably an expandable titanium cage, and I would pack it typically with allograft. More recently, I've been going with some of the newer synthetics that have been showing promise in fusions. If I did a 2-level corpectomy in this patient, I would probably consider backing it up with stabilization as well, just lateral mass screws. Probably wouldn't need a posterior decompression, just stabilization and grafting.
I didn't listen to you. I should have. I put her into a collar, and she was quite grateful, except for making 0 progress with her C5 palsy, which we diligently decompressed from the front. Okay, Mark, take us forwards.
All right, so she returns at 3 months with these x-rays. She's reporting no neck pain, actually. She had actually gone back to work kind of part-time at this point. She was actually doing fairly well. Of note, her C5 palsy on that right side had not significantly improved. Given these images, we actually elected to obtain a CT scan, which I show here.
Wait, that's the posterior. You give it away, give it away, give it away.
Wrong one here. Here we go.
All right, so on brief glance, because we have one other great case to show you. So nothing hurts follow-up like follow-up. This patient was actually very happy. This is remarkable. These are nice slides here. They show basically a complete destruction of C5 and C6. So they've just disintegrated. Dr. Placide, Dr. Reznicek, is this an infection? Is this a mechanical failure? Is this osteonecrosis? What happened here? Oh.
Did you clarify what intraoperative culture showed? Was it the same MSSA?
MSSA. She discharged on 6 weeks of cefazolin and rifampin.
Okay, and is she on any oral suppression at this point?
She was. I don't recall exactly which regimen she was on.
Forgive Dr.
We see these in clinic quite a bit, so Rick can count.
So my concern was that those vertebral bodies were already infected, and this is progression of the osteomyelitis. I wouldn't discount like some osteonecrosis, but my first guess would be the infection was not adequately debrided first time.
Yep. That's my mea culpa as well. I, by the way, had to arm wrestle this patient. Not fair because she has a very dysfunctional right arm, but no.
I like the way you think.
Convince her to come back for surgery. I showed her the images, and she works in the medical environment, and she felt so much better, except for her right shoulder weakness and biceps weakness, but she was actually very happy with this. So again, this is, for me, one of those gray zone cases of mechanical failure, poor bone vascularity, ongoing infection, and overjudgment on the part of the surgeon, that being me, in terms of having hope in healing. I should have backed her up posteriorly. So let's take us to the final image then, in a second, if you can get ready for that. So Dr. Placide, what do we do now? Obviously, we have to do something posterior. You saw the CT, but what do we do with the anterior column now?
So you could probably just back it up posteriorly, but that would be a treatment option depending on how ill the patient was. I would probably recommend redoing the ventral, doing the corpectomies, and then backing it up.
All right, take us forward. We have one more case. So we went posteriorly, as Dr. Kramer showed.
Exactly. So this is the kind of, so that was our thought as well. So our staging was slightly different though. We actually ended up doing the C2, T2 posterior instrumentation fusion first. That's this image here. And then stage 2 was the 5 to 7 corpectomy. Oh. And we ended up using a fibular strut graft to anterior column reconstruction.
And we have a final follow-up.
Looks nice there.
So this is like, how far out is she now? Half a year?
About a year.
About a year out. So the allograft actually fully incorporated. Biomaterials, I mean, I essentially did not put an anterior plate on. We found no signs of infection. We did extensive tissue sampling, but by microscopic, obviously I use a microscope for these cases, assessment, and by cultures, we found 0 infection in the front. So fibular allograft, structural allografts in the presence of infections, what are your thoughts on that?
So I've had cases like this where even the allograft would get infected, and at some point you have to do an extreme and harvest the patient's own fibula, right? So we've probably all been there. I certainly have used the fibula strut a bunch, even in the case of infection. I think from a stability standpoint, that's why I've moved to these titanium expandable cages, and I've not had much problem. Do I have a couple of cases where the adjacent segment is infected and it collapses? Absolutely. But this looks like a great construct.
I must say I stopped using titanium in my UW days because we had some areas where patients would develop late problems with dysphagia, so secondary dysphagia, where our ENT people then were mad at me because the esophagus as a muscle is like an octopus. It kind of grows onto the titanium if it's not protected by a plate, especially the mesh devices. So I went back to strut grafts, which is a very biologic surface, and we actually have an older publication by Jim Schuster, who's now at UPenn, a neurosurgical colleague, who did a great paper in Harborview with long-term follow-up. We had actually very favorable experiences with structural allografts and posterior fixation.
Okay, good.
I just have a question about that case because I'm here to learn from how you all do it. Did your infectious disease team put the patient on additional IV antibiotics? And you may not know. It's a very everybody does it differently. She already received her treatment and her intraoperative cultures were negative. So do you do another 6 weeks? As infectious disease doctors, we way overtreat, and I'll be the first to admit that. I think it's because it's the only procedure we have is antibiotics. So, but I was just wondering if they fully treated her again.
Bingo, yes. So again, we have not the great immediate collaboration that you have in a clinic, but we work very intensely with them and obviously involved them right off the bat. And they did give her another round. I forgot what it was, 6 weeks of IV antibiotics. They put her on chronic suppressive oral antibiotics. She's clinically great. She works full time, but her right shoulder abduction is terrible. But microbiologically, she is basically fine. She actually wants to stop her oral suppressants, which we which you can talk about separately.
And
Yeah,
importantly,
that's a tough one.
during that anterior second stage,
Yeah,
which were negative.
so everything then anteriorly was negative.
Okay.
One last case, a very recent one. Thank you, Mark. Nice case. And here we have Dr. Nick Minasanti, and he's from Philadelphia, from New Jersey. And he was actually involved in this case of yet again another patient who must have come from Richmond, but Dr. Minasali is going to talk about this case he was actually involved with over a weekend shortly after his arrival. Another welcome to Seattle present for you, but the circumstances will look familiar to you in Richmond, I think.
All right, thank you, Dr. Chapman. So this is a mid-70s-year-old male presented to the ER at an outside hospital with severe back and right hip pain. He had also started having ambulatory dysfunction and urinary retention. At that hospital, ER was found to have E. coli urosepsis. A Foley was inserted at that point. He was admitted there. As far as his past medical history, depression, some heart issues with stents, OSA on CPAP. He's also AFib, aflutter on Eliquis, non-smoker, normally ambulates with a walker, lives with his brother. On exam, once presenting to our hospital, so it kind of jumps around a little bit, I apologize. Right knee extension was 2 out of 5. Left ankle plantar flexion was 3 out of 5, and otherwise neuro intact. Right hip exam, he allowed passive range of motion, which was full, but any active range of motion caused pretty significant pain in the groin and back, and otherwise really neuro intact. So imaging on day 0 of that hospital stay demonstrated some degenerative changes, but no evidence of infectious process. So again, he was admitted there, pain control considered. They basically considered this some radicular hip pain, treated him conservatively, and he was on, I believe he was on Rocephin for his UTI, but I could be wrong with that one. Again, outside hospital. And then he basically stayed there, wasn't really improving. He actually started worsening as far as pain. They were trending his ESR and CRP, which was worsening, and then blood cultures became positive for E. coli again. So they re-imaged him on hospital day 13, which demonstrated this significant dorsal epidural abscess from T7 to L5 with compression throughout the affected levels of the spinal cord and thecal sac, as well as associated L3-4 spondylodiscitis and right psoas abscess.
So psoas abscess, I'll go to the surgeon here, Dr. Placide. What's going on with psoas abscesses? How does that happen? Is that a propagation of this disease? Is that a separate process?
So it can be an isolated process. We do see it, and that could account for some of the hip pain. It's interesting that his passive range wasn't problematic, because you would expect you're still stretching the psoas, but the active kind of tipped me off that there may be something going on in the psoas. I see it more often as a spine surgeon as a progression from a lumbar spine infection that spreads into the psoas, but certainly I have seen cases where it's an isolated psoas abscess. But I have another question. So when this patient has urinary retention, right, I assume you did that with a bladder scan or put a Foley in. How was their rectal tone? Because there wasn't anything on the exam were there any upper motor neuron signs? Like, you had an MRI that looked pretty clean, but you had a patient with neurologic deficits. So the question is, would you have scanned sooner up higher to consider? Like, is this thing starting in the thoracic when they show up and now it's just spread to the lumbar?
Yeah, that's a great question. So the hospital he presented to, I don't believe has neurosurgical colleagues. They did.
I'm sorry, I missed that. It was an outside hospital. Okay.
Yeah, initially, and they did get a consult from orthopedics who felt that early on this hip kind of was coming from the back, and then I think at that point they kind of washed their hands of it.
Okay. Thank you.
Yeah.
Great point, though. So let's take it forward, because we want to get to our dual lecturers. So severe thing, I think we all agree this patient has to go to the OR. He is on Eliquis or some DOAC, I don't know which one it was, and
Yeah, Eliquis.
multi-level degenerative disease, DISH, sarcopenia. I would add that atherosclerosis, severe diffuse degenerative changes in association with DISH. Dr. Placide, focal decompressions, yeah, give us the site score.
So you kind of, even if we ignore the fact that he had urinary retention and we blame that on the UTI, he's still a 4, putting him in that severe surgical category. But again, he did have urinary retention, so I think that's something to keep in mind. And just
What do we do, Dr. Placide? Do we do small little laminotomies? Do we do something more global?
Right, so I'm not convinced it needs a stabilization right now. I think this might be done in stages, but for the acute neurologic issues, I would probably do skip laminectomies and use a pediatric feeding tube, for example, to irrigate under the laminectomies that I didn't do. So maybe through the course from the top of his abscess to the lower part, there may be 3 individual laminectomies, and that way I'll preserve some of the posterior elements. I am a little concerned about how bright the disc space is at 3-4, and will that ultimately need to be debrided? But in my opinion, decompression is what's warranted now. And of course, sun cultures from all that liquid we're going to get out of there.
So I take responsibility for what we did. We didn't consult you, but we did something more radical. And the key thing I'm going to add here is the weird thing was this patient had fluid, so liquid abscess, which yes, Dr. Reznicek sent off with aspirates, but the patient also had multiple areas of basically completely congealed abscess material, and it required an active dissection, had necrotic tissue. And when we opened up the disc space, so we did a single level inner body there was a large fluid evacuation. We used a thoracoscopy irrigator to get into that space, and it was a pretty impressive propagation of the disease into 3-4. I justify going down to the pelvis because, again, I felt the disease was going all the way down to L4, L5, this patient has very poor body mechanics. You can see he's amorphous, he has sarcopenia. So I subjected him to a big surgery, but so far he actually did quite well.
Yeah, so overall, just a couple other points. We did send all the cultures. They also came back for that same, likely the same pan-sensitive E. coli. His ultimate plan is 6 weeks of Rocephin. The only caveat is we did attempt to, we discussed with IR preoperatively about the psoas abscess. They felt it was too small to intervene on. We did our best to carefully irrigate through the psoas as best we could from the disc space, but again, we didn't want to cause any further destruction. So at this point, the patient on further imaging from other specialties kind of still has the psoas abscess, but as far as physical exam, doing very well. Strength improved to 5s. Still some difficulty ambulating, but that could be his baseline, to be honest. So that's it.
So a lot to discuss. Any final criticisms before we start with your combined lecture?
I just wanted to say thank you for mentioning that you tried to get into the psoas or do an IR-guided biopsy, because far too often I see either just the psoas addressed and nobody deals with the infected lumbar hardware. We have 2 cases like that right now, or the other way around is they, address the lumbar infection but don't address the psoas issue. So
When you went through that L3-4 disc space, like often you can decompress the psoas abscess while you're there. Do you think a lot of that purulence may have come out from there?
That's what I thought. I thought we had actually done a very nice job. We used distractors. We do a bilateral expanded TPLIF kind of an approach. We have this long thoracoscopy suction irrigator system, and we put large blunt probes in there. So I thought we had a pretty nice cleanup, but again, we don't actively debride the muscle. We hope that we get most of the passive stuff out of there. On post-operative imaging, there still is signal attenuation in that psoas area. So we thought about doing an XLIF approach, but our partner who does great XLIFs waved it off, said that's not enough for us, but our ID doctors are obsessed about this, so that's a big deal.
Okay.
Cliff, would you mind coming up front for a second? So Just wanted to recognize Cliff Pierre. This is his last official week with us. He's been a research fellow with us, done a fantastic job. How many publications?
At least right now, we have about 25, 26 when I checked earlier this summer. Again, we thank you, Dr. Placide and Dr. Reznicek. I actually was part of the invitation sending it out. I saw that you had presented a talk similar like to this at one of the previous spine summits, and I thought it'd be great to invite you in this forum at Seattle Science Foundation. So thank you for accepting the invitation. And again, thank you, Dr. Chapman and the team here at Seattle Science Foundation. It's been great.
So we'll miss you, but we'll stay in touch with you. So we have 2 lectures today, and it's so cool to have both of you with us. I'll start with Dr. Reznicek. You already heard her words of wisdom. She did an infectious diseases fellowship at Vanderbilt and was on faculty there, and then was recruited to the Virginia Commonwealth University in 2014 to establish the musculoskeletal infectious disease service, which is really visionary as an interdisciplinary effort of multiple departments, including neurosurgery, trauma surgery, and orthopedic surgery, of course. And I see many cool things happening there, like outpatient parenteral antimicrobial therapy teams. And she's the editor-in-chief and co-author of a new book called Clinical Cases of Musculoskeletal Infectious Diseases. And she's also working in the Department of Defense grants with colleagues, and she's an active clinician. And Dr. Placide is a professor of orthopedic surgery and chief of the orthopedic spine service at VCU. And he went to a medical school in Eastern Virginia and is a University of Pennsylvania grad from his residency there, and did a spine fellowship at the Cleveland Clinic. And he does spine trauma, tumors, and infection. And again, we heard his prescient words of wisdom as he was critiquing and presaged my complications that I showed. So it's a real pleasure to have both of you with us today, and we're really looking forward to making strides in spinal infections. So thanks for your time and sharing your expertise with us.
Well, I want to say thank you for inviting us. I think this is a topic that Dr. Placide and I we see every day, and we really, I think for those fellows and residents in the audience, I encourage you to join the Musculoskeletal Infection Society. We really need more spine input, and it's a great place to display your work. So I'm just going to share my slides. Let's see. And let me just get to here. Okay, I think you can see. So this is a talk that Dr. Placide and I gave at NASS, and we've just kind of pared it down a little bit for this group. I don't have any financial disclosures. So when I have fellows, the ortho interns actually round with me, and the infectious disease fellows, we kind of go through the nomenclature because I think it's important. We rarely will see just septic facet joint infection, but the others obviously you see. And we did mention before that, you know, epidural abscesses are typically either a primary or secondary process. So we try to delineate which one it is. I think, you know, in the infectious disease world, and I think for patients, it's always important to educate them on how you got this infection, because if I had, you know, 50 cents for every time somebody asked me that, I'd be done with this day job. But so I always tell patients about 50% of the time, I have no idea how you got this infection. And I think we need to be perfectly honest with them. I'm also honest with them when I say, you may not become pain-free, and we need to really set those expectations. But the majority of these infections are hematogenious. So I don't know how much your infectious disease doctors provide lectures for you, but we are bacteremic almost every day. When we brush our teeth, when we go to the dentist, when we chew gum, most of the time our body's able to get rid of it, but often it can either seed an arthritic area or recent trauma or any place where there's hardware. So Dr. Placide will go into this a little bit more, but I think it's important for our ID fellows and to know the pathogenesis that typically it involves initially the vertebral body metaphysis. And as you were saying previously, the numbers are just increasing, unfortunately. We still have an increased male to female ratio, but I think, you know, our population's aging. There's an increased number of immunocompromised patients. So here at VCU, we have infectious disease service that's just dedicated to our transplant population, both bone marrow and solid organ. There's an increase in spinal procedures, fusions, laminectomies, so we're seeing infections after that. Important to know the pathogens. So I'm always thinking with my fellows, first we talk about the host, then we talk about what is the diagnosis, and then what could be causing it. Most common is still Staph aureus. Don't forget, with hardware, you have more indolent organisms that normally wouldn't necessarily cause infection. I do want to highlight, so coagulase negative Staphylococcus usually is in the setting of spinal hardware. However, the other situation where you need to be aware when it affects native spines is in patients on hemodialysis. So patients who have their dialysis access used frequently can get transiently coag-negative staph bacteremia and then can get a native spine infection. IV drug use, you definitely have to expand to more gram-negatives and fungal pathogens. Unfortunately, Dr. Placide and I have a large group of patients with these weirder pathogens like Candida. You just presented a patient. Always remember urosepsis in that age group. And then don't forget, for boards, I still have yet to see a case, but brucella is the classic for unpasteurized dairy products. So I get asked this a lot by the ortho residents that are on the spine service. Typically, I do not request fungal and AFB cultures unless I have a concern, unless they have a risk factor or they have previous negative cultures. But remember, your standard Candida is going to grow on bacterial cultures, so you really don't need a separate fungal culture, and you're just burdening your micro lab. So you all know this, that the majority of these infections are in the lumbar spine, and then we have a couple cases of POTS that we follow, and that's typically upper lumbar and lower thoracic. I think this is important, especially for people who have never seen this process. I was surprised that one of your patients had a fever, because it's really not that common, at least here, less than 50% of our cases. But what I tell my learners that are on service with me is they have to have pain. I mean, it says 15% maybe pain-free, but I feel like they all come in with pain. We have had cases with normal ESR and CRP. That's why I usually don't put a whole lot of emphasis on one data point, and I usually trend them along. I think this is important. This was a really good paper that came out in our journal, Clinical Infectious Diseases, that I think it used to be an acute process in young patients, and I think you see it out in Seattle is now, like with your patient with the E. coli, and Dr. Placide and I, it seems to be a lot more elderly individuals, and it's just often with relapses. We have a couple patients with E. coli and Serratia that have relapsed. So for my initial workup, all my patients get 2 sets of blood cultures, hopefully before the ER hits them with vancomycin and everything else. They do get an ESR and CRP. I do leave the imaging up to Dr. Placide's team, depending on what they request. In select patients, I'll get the following studies: fungal blood cultures, PPD or IGRA for TB testing, but really it's not very often that I end up getting those. I do push for an image-guided aspiration. I will say here at VCU, our success rate is relatively poor. We're probably at about 30% sensitivity, but to me, that's better than nothing. We have a little bit of a problem here where our radiologist will not approve the order until I see the patient, which makes me feel important, but is also ridiculous. So the hospitalist typically needs my consult first, which I don't really understand. But I get the aspiration if the patient does not have positive blood cultures with MSSA or MRSA, or they were bacteremic years ago and I don't know exactly what's causing it. So in the infectious disease literature, our guidelines are quite old. They're from 2015. If anyone wants to work on them, please feel free. Our guidelines recommend that if the first test is negative, we recommend another image-guided biopsy. I have yet to see that happen. Typically, they end up going to surgery, or we just treat them broadly. So although the infectious disease guidelines recommend that, I've never seen it be put into practice. So when they do image-guided biopsies, we had an issue here where they were only sent for culture. So I actually definitely want pathology to look for, could there be granulomas or malignancies? The other thing is I typically have a part of the specimen saved so we can send molecular diagnostics or PCR later on. So that's really important, and some institutions are starting to do that. So acute phase reactants, just to bring them up, I think everybody, puts all their eggs in the CRP basket. I'm not a big fan, like I said. They rise with anything. If you were in a car accident, if you had any stresses. So I do use them to trend. Remember, like I said, they go up with, almost anything, ESR, especially with age and other chronic comorbidities. And I think this slide is really important. I put this together last year because, like I said, people put a lot of weight on these. But you can see the studies I highlighted that even after 4 weeks, which ones have a higher risk of failure. But then if you go down to the bottom, when you see ESR and CRP increase within the first few weeks of treatment, they can increase, but many of these patients do fine. And I want to highlight for those of you that don't typically manage outpatient IV antibiotics, patients will often have an elevated ESR and CRP just from being on IV vancomycin or IV something. It's just a stress to the body. So I really like to get ESR and CRP after they are off of all antibiotics to see where they stand. So take home points, remember that I saw that one of your CRPs was really, really high because the ranges change from 0 to 1 or 0 to 10. Some of these patients, you probably see the same, have RA or lupus or some other autoimmune disease that can raise these. A lot of infectious disease doctors and maybe some at your institute get ESR and CRP with our weekly labs. I don't do that because I don't feel like it changes anything. So for example, if they're elevated, but Dr. Placide and I see them in clinic and they're doing well, I'm not going to tell him to take them back to the OR. There's nothing I'm going to do differently. And I tend to trend them. So I'll get them when they're in the hospital one time, and then maybe after they finish IV antibiotics, and then maybe 4 to 6 weeks later. So a little bit about antibiotic management, since that's mainly what my contribution. When you were in medical school, you learned this 6-week thing, 6 weeks, everybody talks about 6 weeks. Well, you'll see that that's going to probably go away in the years to come, mainly because the Oviva study that came out of Great Britain is showing that we could use a lot more oral antibiotics, and we probably don't need that long of a duration. I will tell you, I get pushed here, not by Dr. Placide, but some of our other surgeons, to extend antibiotics to 12 to 18 weeks, which has not been shown to be beneficial. The person probably just needs surgery. So where did this come from? So sadly, this 6 weeks came from a study in 1970 in the pediatric literature, where they found that there were 3 to 4 weeks for infected bone to revascularize. Infectious diseases jumped on this, and we came up with this osteomyelitis is really controlled without prolonged IV antibiotics. So you'll see in the diabetic foot literature that we're using shorter courses. There was a lot of problems with this study in 1970. They only had parenteral penicillin. We have a lot of oral antibiotics that have good bioavailability now. So antibiotic duration and relapse, I'm just going to tell you what I do. So yes, I still do 6 weeks, even though I told you we probably don't need to. I do go a little bit longer with Staph aureus. I always tell my patients, well, I often don't tell them right to them, but I would rather have an E. coli infection than a Staph aureus infection. Staph is just tricky. It's really hard to get rid of, and there's a higher rate of relapse. So I tend to go longer in my Staph aureus patients. But even then, I usually don't go longer than 8 weeks. And if there's still an issue after 8 weeks, that's when Dr. Placide and I will usually get repeat imaging and they possibly need surgery. So this is one of the studies that's often quoted in the ID literature, that there was 6 weeks was non-inferior to 12 weeks. And so this is important too, that we really, really try to cut it off at 6 to 8 weeks. So this is more of that study, and I can send you these slides. I think this is one thing I wanted to bring up because I struggle with what to do with IV antibiotics if they had surgery. So this was a retrospective review. They looked at what were the independent risk factors of recurrence, and if they did short-term IV antibiotics versus long-term. And this is just a pie chart of the organisms they isolate, which is similar to what we see here. So what the first goal of the study was, they found that there were 2 independent risk factors for recurrence, and that was positive blood culture or paraspinal abscess. And I think we see that every day in our practice. So I am a little bit more cautious with patients who come in bacteremic or who have an abscess. I just want to point out all these patients did have surgery. Many of them had instrumentation. But as you can see here, so if you look at recurrence rates, if they got less than 3 weeks of IV antibiotics or greater than 3 weeks of IV antibiotics, it looks like in the low risk group, we could probably get away with a shorter duration. I'll tell you, where do I use this clinically? So I asked you before, if they already completed 6 weeks of IV antibiotics and then Dr. Placide does a surgery and their cultures are negative, I will not give them another full 6 weeks. So I will often do 2 to 3 weeks and then transition them to oral antibiotics. I mean, antibiotics are not risk-free. We see a lot of C. diff. So I have changed my practice in this sense that a lot of ID physicians just reactively throw them on another 6 weeks, and I actually tend to shorten them for their second course. So this group hypothesized that appropriate duration of IV antibiotics after surgical intervention could be guided by the risk factors, and I agree. So I really am a little more aggressive if they have positive blood cultures or paraspinal abscesses, and I tend to shorten the course if they do not. So take-home points, I can't emphasize number one enough, and if we want to talk later on about how I created this clinic, it is essential for us. It's essential for the patients. We must have a multidisciplinary approach. I avoid putting all emphasis on ESR and CRP. It's really important for us in the ID world to try to identify the etiologic agent. I know many ID docs are often pushing for surgery. I get that it's not always feasible, but longer antibiotics are rarely the answer also, and we have to really stop this 12 to 18 weeks of IV antibiotics. I really try to be realistic, not negative, but realistic to the patient, that this is not like strep throat where you take 3 days of amoxicillin and feel great. I'm very realistic with them that it's going to take a long time for you to feel better. But we will be there with you during this journey, both Dr. Placide and I, I try to get realistic expectations. And I'll pass it over to Dr. Placide.
All right, thank you. Let's see. Okay. Can everyone see the screen?
Yes.
Yeah, okay, great. So I also want to thank the Seattle Science Foundation for this invitation because this is something Dr. Reznicek and I are, I guess, passionate about only because our region is not. So we're pretty aggressive with managing these people, not necessarily an operation being aggressive, but taking hold of this. So I have no disclosures. Let me gotta fix my screen.
We see you fine from our end, so.
Yeah.
Okay. So let's go back then. All right, so no disclosures. So why do we operate on a patient with a spinal infection? So first of all, if we have a negative image-guided CT or fluoroscopically guided interventional radiology biopsy, it's negative. I know that some of the old orthopedic literature says that do a second one, like the ID literature, but I agree with Dr. Reznicek. We rarely do that because it's not likely you're going to get something, and then you're going to waste another week before actually treating the patient. Because if this is a patient that has an infection that is not meeting criteria for an operation, you really want to identify the organism and not just put somebody on multimodal therapy. So then there's a consideration to do an open biopsy to get significantly more tissue than an interventional radiologist would get. If the spine is unstable, you want to stabilize the spine. If somebody has neurologic deficit, we decompress the elements. If the patient has already gone through, say they've identified an organism and they've already failed their IV antibiotics, they have miserable pain, or they have progressive destruction, as in one of the cases you guys presented, that's a reason for considering surgery. Now, just to say, if we have a patient that we've operated on for a spinal infection, you may have these same questions. Well, how do I know the infection is gone? Well, we don't, and we tend to not do repeat imaging if the patient is clinically doing well, right? So just like Dr. Reznicek is not hanging her hat on acute phase reactants. I do not hang it on repeat imaging if the patient's clinically doing well. And I have intractable pain on the slide and a question mark. I would argue that is an absolute reason to intervene surgically. There are patients that may have minimal destructive change, no neurologic deficit, but they're nearly bedbound because of the pain related to the bony destruction. That's an indication for surgery, in my opinion. And other potential reasons, as we brought up on one of your cases, is using some of these published classification schemes and algorithms, and also including knowing risk factors of what patient may fail non-surgical treatment. And we're going to get into this a little bit more in the talk, and I'll get through this quickly. And we have to recognize non-operative care is a reason. We see some of the classification scales and literature talking about bracing. There's no absolute data that says that bracing is going to affect the overall outcome, but it actually can help with the pain and help mobilize a patient. So we will occasionally use bracing for that. So I'm only going to touch real quickly on some of the pathophysiology because it's important when you come up with decision-making on how you're going to treat a patient. This is just some of the basic science of what is seen histologically in acute versus chronic osteomyelitis. And remember, the grand majority is in the ventral spinal column. It's only about 5% or so that occurs in the posterior elements, like a facet, septic facet arthritis, or posterior element osteomyelitis. So remember that discitis, it's different in children. So Dr. Reznicek outlined this nicely. What ends up happening is the metaphyseal bone, or the bone adjacent to the end plate of the vertebra, is well vascularized in the adult. In a child, there are vascular channels that still go into the nucleus. And until those channels go away, you can have seeding of the actual nucleus and disc space in a child, where that tends not to happen in the adult. What happens is the end plate gets infected and it starts destroying the end plate. The disc is relatively avascular. So now the infection collapses through the end plate, and there's really nothing to stop the enzymes of the bacteria from eating through the disc space into the adjacent vertebra. That's why we have these classic pictures of a destroyed end plate above and below a particular disc space. So what happens when you have a progressive infection? Well, these are things that we all are concerned about. Progressive destruction, instability, deformity, right? That causes significant pain. You can develop a secondary abscess related to the spinal column infection. You get retropulsed bone fragments, granulation tissue, even more neurologic deficit. You have the neurologic compression. And let's not forget that not only does the compression cause ischemic changes to the neural elements, right? You're compressing the vessels, the anterior and posterior spinal arteries, but infection, and we discussed this in one of the cases, there's a local vasculitis, so there's even worse blood flow to the infected area. So that needs to be a consideration. You can have a relatively minor cord compression, particularly in the thoracic area, and somebody can have a significant neurologic deficit. And I've actually seen cases where providers have said, oh, it's not that much compression, that's not causing the problem. Well, it is causing the problem, and this is one of the purported reasons. So classification schemes that are published by Pola et al., they were mostly talking about biomechanical changes and neurologic changes, and then coming up with a surgical or a treatment algorithm, whether it was an operative or non-operative treatment. What we've talked about already today is more of the site evaluation score. Dr. Chapman brought that up, has multiple categories. So we look at the neurologic status of the patient, and we use this clinically. I go over this with the residents, they're taught this. We look at the location. We look at the radiology. So CT and MRI, we prefer to have both imaging. We can get them relatively quickly at our institution. I know that not every place is like that. We look at pain, and then comorbidities, which are significant when you look at who is going to fail non-operative treatment. So in conjunction with a grading scale like this, and this was already brought up in a previous case, we look at these other factors. Why are they going to fail medical management or non-surgical management? Are they older, diabetes? Methicillin-resistant staph is not easy in the spine to resolve without surgical debridement. And certainly somebody with a neurologic deficit, we're leaning towards surgery. So it has been shown, not only in spondylodiscitis, but epidural abscess, that early recognition and treatment has overall better outcomes for the patient. And early surgery is better than doing surgery after they've already failed a full course of non-operative treatment. So what do we do in surgery? There's only three things we do in surgery, right? In spine, we stabilize the spine, we correct deformity, we decompress the neural elements. We add a fourth, an infection. We have to have a significant, adequate debridement of the infected material and send it for specimen. We've had cases where patients have had positive blood cultures and they had a very benign looking osteomyelitis and they're on the appropriate antibiotics and they progress over time. And then they end up having an operation and recultured and they're growing fungus in there with the bacteria. So that was missed up front. That was really not treated adequately. And as you all know, you can do a standard open procedure, which is most of my practice. I have partners that do minimally invasive partial corpectomies and corpectomies. And you can address spinal infections from an anterior, lateral, or posterior approaches. Decompression, stabilization. This is all we touched on this earlier, different types of interbody and corpectomy type of reconstructions. Titanium tends to be better than PEEK or stainless steel with respect to biofilm. There's some new data that carbon fiber may not be problematic in the face of an active infection, but we do know that placing hardware in an infected spine is okay as long as there's an aggressive debridement. You stabilize the spine. You can't just debride it and leave it grossly unstable. You stabilize it and you have the appropriate targeted antibiotics for that particular organism. So just to summarize this, it's a very reasonable option. In our area, we think spinal infections tend to be a little bit undertreated. But recognize it early. And unfortunately, a lot of people with a spinal infection, they show up with ongoing disease that can be a month or more. Think about titanium and alloy implants. Be aggressive with your debridement and absolutely stabilize the spine. And no question, team up with an infectious disease specialist. That's it. 11 o'clock.
So congratulations on great talks and that teamwork and a visionary concept. We'd obviously like to be in touch with you later because we have a number of publications that we'd be interested in putting together. So going back to the hardware in a infected spine, do these patients have to be on chronic suppressive antibiotics then? I still get requests from ID doctors to take the hardware out in a patient who, from my end, looks perfect and is very happy, and they want the hardware out for final disease, quote, eradication. Is that an anachronism? Is that something that's just still stuck in 1970s literature from New England Journal of Medicine?
Yeah, I think so. So I think Dr. Placide can agree. I've never requested him to take hardware out in a stable, happy patient. So the way I do it is I leave them on oral antibiotic suppression until we have evidence of fusion. So this is why it's really important that he and I see the patients together with imaging. I also, and we talk about this in the ID world, it's a case-by-case basis. I mean, I can't keep someone on Cipro forever, or I have patients who just don't want to do it. But if they're compliant and I have an appropriate oral option, I usually go about 6 months, sometimes up to a year. Some of these patients are 52 years old. You can't keep them on an antibiotic lifelong. And then I don't request to take the hardware out because, if the fusion's stable, then hopefully if it ever needs to come out, then it's doable. But I've never requested to have it taken out. Right, Rick? I don't think so, unless it's infected.
So no, that's a very good point. So when we have a case we operate on that's instrumented for infection, at a minimum, they're followed up to a year. Minimum.
Yeah, with both of us at the same time.
And we don't do, there was a comment, PET CTs, MRIs, it's plain radiographs, and it's more of a clinical exam. Like, how are they doing clinically? They're doing well. And then at each of those appointments, Dr. Reznicek and I will go back and forth about, what's our next step? Are we going to do more imaging, or are we going to keep, we're worried about this patient, we're going to keep following them beyond a year?
Yeah.
Yeah.
But for that first year, we're with them together pretty much every visit.
I have a question in the chat room from Dr. Maximino Tellis-Gitz. He always has great commentaries. PET-CT, is that something that we can use as a better long-term follow-up tool in ID patients with musculoskeletal infections?
So that is definitely a hot topic, especially in spines. I think that it does have a role. The issue is we have difficulty getting it covered insurance-wise. Some of the larger institutes that are doing more, say, prosthetic joints in us, they have ongoing studies now with PET-CT. They PET-CT all of their prosthetic joint infections that are failing. I do think, and I can, put some papers up, there is some role for PET-CT. Here, personally, we've had trouble getting it covered insurance-wise.
Can I ask a question about a PET-CT? If the patient is doing well a year post-op,
No, I
why
wouldn't
would
get
you,
it. Yeah.
why would you
No,
get that study? You're not going to reoperate if the.
No. So I
Oh.
think that's really important. So I far too many times see repeat imaging for no reason. I do not repeat their imaging unless they have unless they had an abscess that was not debrided. And I think Dr. Placide agrees. We repeat their imaging if they come in with a new neurologic deficit or worsening pain. But otherwise, imaging lags behind. It's not going to change our plan. Yeah, I'm talking about PET-CT if there's some concern for ongoing infection.
Okay.
Great stuff. Great questions. And Dr. Salazar, thank you for your nice comments also from Professor Jorge Salazar. Next question to both of you, but I'll start with Dr. Placide here. So sometimes when I have just severe infections with a lot of osteonecrosis, I actually put antibiotic spacers in, very similar to my trauma colleagues. I'll make a PMMA spacer and fill up a vertebral body defect with antibiotics like Vanc and Tobra, and then at a later point take that out. Is that overkill? Is that being too careful? Or what do you think about that kind of a staged reconstruction concept in a severely anabolically riddled patient?
Right. So I think that's very reasonable if you have a severely infected patient. What I've done more recently is, in the case of, say, for example, multi-level osteomyelitis, it's going to need multiple levels of corpectomies, is I will use a standard mesh cage and not only pack it with allograft or whatever synthetic, but I will mix in there. We recently had a patient that had not only a staph multi-level osteomyelitis, but fungal osteomyelitis. Yeah. After a multi-level ALIF standalone procedure, they all got infected. Now the patient was a poor host, so we packed bone graft, and then we put these small beads that resorb, and you can mix antimicrobials and antifungals in those beads, and they elute the antibiotic over the course of weeks, maybe even a month or more. So that's what I've done for these really tough ones, but I think the PMMA elution is probably just as good. But doing it the way I was just describing, there's not a reason to go back and take the cage out or anything like that.
And how long do those antibiotics actually elute? If you can answer that, if I have a PMMA scaffolding, how long can we expect that to actually go for? And maybe Dr. Reznicek can also address that. But from your end, how long do you think that actually works?
Well, I don't do the PMMA technique, but those small stimulant beads, which are probably similar to what you're talking about, probably not more than a month.
Yeah, the data shows that the highest rates of elution are within the first probably 48 to 72 hours, and then you get a trickle after that. The literature is not very supportive of local antibiotics. I'll say we do it, and I'm a proponent of it. Sometimes we call it fairy dust because I'm not sure it's doing anything. I do have to say for the fellows and resins there, just be cautious with your Tobra and Gent. So we've had two cases of acute kidney injury because the surgeon thought, well, if we use a little bit more, must be better. Not a spine surgeon. My feeling is if we do no harm, that's okay. I'm okay with local antibiotics if we're using the correct dosing, and also Dr. Placide's really good about this, talking to me ahead of time. So if it's VRE, don't put vancomycin in there because the V is vancomycin and the R means resistant. So we need to come up with something else. The other thing, I don't see this that much in spine surgeries, more in traumas and diabetic foot infections. Stimulant beads can sometimes be difficult because they drain. And we don't know in clinic if the drainage is the stupid beads coming out or if it's really a problem. So, you know, they're good and they're bad. But yeah, I think we do a decent amount of local antibiotics here, both for, open fractures and spine surgeries. I think we just have to make sure we're using the correct dosing and actually using the correct antibiotic for the pathogens we're suspecting.
We're at time, a little bit over, but we could carry this on, as far as I'm concerned, for a whole day. Maybe we have to have a spine infection symposium.
Yes, please spread the word.
This weekend, we have our spine deformity course chaired by my partner, Dr. Mir Abdul-Jabbar, with Dr. Stephen Lewis as co-chair from Toronto, right here live. So do join us this weekend. This was a fantastic session. And again, we have a phenomenal response from our audience in the chat room from around the world. So thank you, colleagues from around the world, for your interest in this. And again, we saw the interplay of infectious diseases, stability, and neurology, as well as patient physiology, well represented by the two specialties here, Drs. Reznicek and Placide. It was a true pleasure. Thank you for your time. Thank you for your education, and a conversation to be continued, I'm sure.
Thank you for having us.
Thank you very much. It was a pleasure. It was an honor.
Great. Have a great day. Take care. Bye-bye.
Thank you.
Bye-bye.